Okay. So hi everyone, welcome and thank you for joining us today for a webinar on addiction and depression. My name is Harshini Sudhakar and I'm the president of the Bedford HOSA Health Club.
And I'm Nori Toledano, the vice president, and our panel this evening is very exciting. Today we are joined by Dr. John Whyte and Dr. Damon Tweedy. Dr. John Whyte is a physician and corporate executive with a combination of government and private sector work and is currently the chief medical officer of WebMD. Dr. Whyte leads efforts to create meaningful change around important and timely public health issues. He completed an internal medicine residency at Duke's Medical Center and earned a Master of Public Health and Health Policy and Management at Harvard University. He has written in the medical and lay press, including 2 best-selling books.
Dr. Damon Tweedy is an associate professor of psychiatry at Duke's School of Medicine and a psychiatrist within the Durham Veteran Affairs healthcare system. He completed both his medical school and specialty training at Duke. Dr. Tweedy has written extensively about the intersection of race and medicine, both in academic journals and popular print publications. His 2015 book, Black Man in a White Coat, A Doctor's Reflections on Race and Medicine, made the New York Times bestseller list. Thank you for joining us, and we're really excited to get this evening started.
So first off, would either of you like to talk a little bit about why you chose the fields that you did?
I'll just say I actually started out in, so went through medical school and started out matched in internal medicine. I thought I was interested in becoming a cardiologist initially, actually. Psychiatry was low on the radar, and it was only sort of a combination of some of my experiences during that internship year, and actually had some colleagues, classmates who suffered some mental health challenges, and it was striking to sort of see the sort of challenges, the stigma, and everything that sort of kind of was at work there. And anyway, a multitude of factors kind of led me to psychiatry, but initially I never imagined that I would have been interested in it. I actually started off thinking I was going to become a cardiologist.
Well, first I want to congratulate all of you as high school students, showing the initiative and raising awareness of this important topic. And it's really a privilege for me to share the stage, the virtual stage, with Dr. Tweedy, who is a great writer and really is a thought leader on these topics. Like Dr. Tweedy, I had a different plan in mind. I thought I was going to be a surgeon, and I had been interested in that for a very long time, but then I realized I was interested in health policy issues and these other aspects, and it's very hard to do that when in surgery you need to learn the technical skills. And I was very interested in that longer standing relationship with patients and in treating the whole patient. So I went into internal medicine, and it's a great lesson from both of us as many doctors. You think you're going to be one thing, and then as you learn more about it, you have to be open to different career paths and different ideas. So it's been a great journey through medicine.
Yeah, that's really cool that even though you both took more of an untraditional pathway to medicine, you both reached a really great career and have been helping so many people.
So now, would you like to talk a little bit about, in our community, we've seen that the words addiction and depression are often overused. And we just wanted to know, as professionals, how would you define these words in your own way?
Yeah, and again, I want to echo Dr. Whyte's comments about how great the work you guys are doing. And I read your post about the COVID and vaccinations and everything, and it's just really just thinking about myself at your stage of life. And yeah, you're certainly several steps ahead of where I was on this path. So I just wanted to sort of start with that. But as far as your specific question about addiction and depression, I mean, so there's sort of formal definitions. If you think about there's what they call the DSM, which is DSM-5 is and that's what the sort of is used to sort of officially classify disorders. I mean, so that's sort of like this kind of, there's like the official definition, and there's sort of more like the kind of colloquial kind of what we do in everyday life sort of thing. And I think what you're suggesting is that people might use those terms a little bit too loosely, and maybe the danger with that there's potential good in that it may lessen stigma, but the potential downside is that it might sort of trivialize the extent to which those things can really be problems for people. So I think there's like that kind of double-edged sort of thing. But Dr. Whyte, what are your thoughts about some of that?
No, I agree. And I think there's really a greater awareness in the last few years about the mind-body connection. And as Dr. Tweedy points out, there's these formal definitions of what depression is and in meeting certain criteria relating to mood as well as addiction. But the important component here is that physiologically and biochemically, they're different conditions. And we treat them differently, whether it's pharmacologic or in terms of other types of therapy. So that's really an important component as we think about these terms. We use them kind of in a colloquial sense, very casually. But as Dr. Tweedy says, we have to be careful because how we diagnose them are important because that's often going to determine how they're treated. But I also agree with the point that you all kind of alluded to. And great, we're talking about these words and talking about these diseases and conditions, because just by talking about it, it helps remove stigma. There still is a lot of stigma, especially in youth and young adults, about being labeled as someone who has an addiction or someone who has depression. But there are biochemical differences in one's brain that can also account for these conditions as well. And that's important to keep in mind. Would you agree with that, Dr. Tweedy?
Yes, I mean, particularly like if you think about, addiction, or of course, in our field, we will say substance use disorder, whether it's alcohol or whatever may be the case. I think it's very true. I mean, I think there's a lot of like this sense of, there's some of the language that we use in these fields. Like you'll hear people describe when they get tested, they're saying, well, is it dirty or is it clean? What is your drug of choice? And so there's certain language that's used that sort of frames it as people making conscious decisions willfully that are destructive, so there's that certain stigma that's been there for a long time. But to be honest with you, as far as things that have been mapped out with the brain, the pathway of addiction is pretty well characterized. And so it's a striking juxtaposition that where we actually have pretty good biological understanding of it, yet we're still sort of fighting this immense, long-standing sort of social stigma. And so I think those two things we're at a point where we're sort of, those two forces are still are fighting each other. But I think that we are certainly moving in a direction where people are getting a much better understanding of the biological component and how that then impacts the social, component to it. So yeah, I agree.
Yeah, and what would you say are some either like personal or medical risk factors that can make a person more prone to addiction or depression?
I'll let Dr. Tweedy answer that.
Okay. I'll take a. So a couple of things. Because even here we're sort of, you're using those two things. We're not using them interchangeably, but they're certainly not interchangeable. I mean, there's certainly overlap. There are people who experience both. People who have depression, significant clinical depression, and also have struggling with a drug use disorder, and they can overlap, and one can make the other worse. So there's certainly that for sure, but they're also not identical, right? There's some differences between the two. Risk factors, certainly some of the things that are your family, certainly, I mean, just like many other things, we don't get to choose our parents and that sort of thing. So certainly family members have those issues that put you at higher risk. Certain environments that you grow up in, certainly higher risk. But if we think about it, particularly thinking about like addiction, a lot of it, much of it is biological, but there's also a learned component. Like how do people in your orbit, how do they cope with stress? And so if you grow up and you see that you're, a member of your family, every time they're stressed, they reach for this bottle of certain, pills, they reach for the alcohol bottle, reach for the bottle and they drink, there's certain learned component to that as well, right? So certainly those things can put at additional risk. So I would say there's probably a combination of both, just like most things, a biological feature to it, a genetic aspect to it, which is clear. There's studies. There's been twin studies, all sorts of studies that looked at the sort of the biological basis of particularly alcohol use. You see that, but there's also a social dimension to it. Certain cultures, have different relationships with alcohol. And I don't know. I mean, we might go into this later. I think in a lot of ways, our culture has a pretty unhealthy one, a relationship with it. And so I think that then itself furthers some of the challenges for people who are vulnerable. Then that puts them at additional risk. So I encourage people to kind of know a little bit about their own risk. So me personally, my parents don't, it's not risk there, but like on both sides of the family, there's pretty significant alcohol use problems, pretty significant. And so that made me be more cautious as I thought, because I was thinking about that sort of biological basis on both sides. As I was, coming along in college and stuff, some peers maybe could approach it differently, but I felt like there was an extra degree of caution that I maybe needed to exercise, given the extent to which I had some pretty severe, family history of alcohol-related problems that cause very serious problems. So I think that's really important to know.
It's always amazing how they do twin studies. Separate
right?
Twins. I'm always fascinated by that. That's another conversation. But I think it is that important component about environment, which nowadays we often use the term the social determinants of health. So your zip code is as important as your genetic code, and where you live, and whether you have access to environments where you can walk out and not be fearful, and get physical exercise and get that release of endorphins from physical activity, that you're not having this sense of danger or fear when you're living in home. So it's like most conditions, and these are real diseases, that environment plays a role as well. And I love Dr. Tweedy's point about he was cognizant about what his risk factors might be early on, and really was sensitive to that. The other thing I see with folks is, moderate alcohol consumption. We just talk about alcohol is considered no more than one drink for women, no more than 5 days a week, no more than 2 drinks for men, no more than 5 days of the week. And I'm not making this up when I say that to patients. They're always like, "No way!"
Exactly,
because their equation of how they're interpreting it is completely different than the norm. And you learn in medical school to ask a question, what about alcohol? You sometimes give them a number, because people lose sense of what is normal. So people say when they don't drink a lot, sometimes you would give them a number. Do you say 4 beers a night? And you'd be surprised. A lot of people will say, "You're crazy." No, not 4, but many will say, "Yeah, about 4 or 6." And then you realize they're not self-aware, and that's an important component as well when we think about these issues. In terms of depression, people are in general sometimes can be more self-aware than in terms of addiction. It can take a while till they realize there's also the concept, without getting too specific, about dependence, as opposed to different levels of addiction.
Yeah, that's very true. We were wondering, like, kind of jumping off of that, like, how have you seen different regions of the US, for example, like urban, suburban, rural, differ in regards to the prevalence of addiction and depression?
Yeah, well, sadly, we know in rural health, a group of individuals across the country that typically don't get a lot of attention, don't get a lot of care, partly because the lack of providers there, partly because of the challenges in some of those areas. We do see lots of substance abuse. Substance abuse is prevalent everywhere, but we do obviously see it in underserved areas, socially impoverished areas. We see it in others as well. And I think the COVID pandemic has made it worse, because people have looked to substances to help them get through the pandemic. And I think we're seeing it across the country, not localized to one area. And sometimes it also becomes, when you're in a suburban area and you may be more affluent, how that information is reported or how you're labeled is different. In terms of, we know that folks that are from minority populations are more likely to be labeled as an addiction issue, as opposed to perhaps some affluent Caucasian folks. So this is a issue all around the country. I think it's exacerbated in rural areas and socially, economically disadvantaged areas. Would you agree with that,
Yeah,
Dr. Tweedy?
yeah, absolutely. And I think your point about sort of the socioeconomic aspect of it is very true. People who are more affluent might their substance use or addictive disorder, because there's stigma with it, right,
Mhm.
might be couched as something else, and they might be framed as having primarily depression or anxiety, and this other part may be less likely to be addressed, or to be sort of cataloged. Whereas in more urban areas and in some of those rural areas that Dr. Whyte's talking about, you're more likely to see people get that addictive label. Another thing that I've noticed is that because there's a sense there's kind of a sense, even as stigma has decreased with like things like depression or anxiety, it's still there, but it's decreased. In some ways, it's more acceptable to sort of say that you have that than to say that I'm addicted to opiates, or to I'm a drug addict, right? And so there's still different degrees of how that stigma plays out. And there's also geographic variation in terms of which particular substances you might see used in different settings. So as you become a more experienced physician, you might find that in certain areas, you're more likely to see this particular segment of the population use this, whether maybe cocaine more in this particular location, but in other parts of the country, you might see someone where the drug of choice is, methamphetamine. Someone said people use drugs across the spectrum, but there is definitely geographic variability in different parts of the country. Here in North Carolina, it's very rare to see someone with like methamphetamine. It's almost like non-existent, whereas like in West Virginia, Tennessee, that area is quite prevalent. So there is some variability, but the common ones you're going to see are certainly tobacco, alcohol, marijuana, those kind of trends in pretty much everywhere you go. But some of the other ones are going to be more geographically oriented. So there's a lot.
What is the latest data on marijuana? No, I'm asking questions. What do we say about marijuana nowadays as we think about these different substances?
In what sense? What do you mean?
In terms of, do we consider it an addiction, a dependence? Do we consider it harmful in terms of recreational use?
Yeah, it's certainly in the gray area, right? So it's because when you think about in the DSM-5, there's something called cannabis use disorder. So it still fits within that. And I'll see people who smoke daily and smoke large amounts, and in their life they don't really function very well, right? And so there's certainly, but of course, I think there's a difference between. I think while we can agree that the criminalization of it is a problem, I think there's a distinction between, you can say that's a problem, which I think it is a problem. The criminalization of marijuana and other drug use is problematic. It doesn't necessarily mean that it's a good thing for people to just go out and consume it. So I think we have to sort of have nuance there. But yeah, I think it's interesting because we have certain states who have, it's legal in certain states, and certainly it's changing in a lot of different ways. And I think one of the challenges is that it'll be harder to like, even just give an example. Historically, when you do drug screens in patients in the emergency room, I'm sure Dr. Whyte, you're familiar with it. Marijuana used to be one of those ones that would be commonly tested, and now there's a movement to sort of not do that. You see that not really being part of the standard battery, kind of finding itself more in that alcohol, tobacco kind of category, right? Where it's legal and people can consume. But it's mixed, I guess I would say. If you ask my personal experience with it, I certainly would not support criminalization of it. I think those efforts are good, but to sort of tear that down. But there are concerns about it, particularly in people in your age, in younger people using it. There are real concerns. And as a psychiatrist, there's definitely caution that should be exercised. Just because something's legal, and it's freedom to use it, doesn't necessarily mean it's necessarily a good thing. I guess that's sort of how I for an individual.
Yeah, and I've been seeing in a younger population a lot more vaping.
Yeah, I was going to tell you. Yes, tell us about that.
It's safer than smoking. It's not harmful like smoking. The names of the different flavors, sound like, hey, they're pretty cool. So that's been an issue that I've been seeing in younger patient population, a lot of vaping, and people even saying, well, they gave up smoking to vape. But, I'm not sure that's the best approach. Smoking is more harmful, but we do know that vaping has lots of health consequences as well. And it goes back to this issue of awareness and self-awareness in terms of what you're dependent upon. And, you know, I'm sure Dr. Tweedy has seen this as well. We all see patients in terms of nicotine dependence. Oh, I can quit at any time. But really, it becomes challenging for people once they develop that physiologic dependence on the drug. And these really function as drugs that they're addicted to. So it becomes a very slippery slope as well.
Yeah, I think it's important for us to, I think historically the sort of approach to addiction has been about willpower and strength and those sort of those terminology. I think we really need to think about how we reframe that, because I think that then can lead people towards feeling really getting in depressive spirals. You know, I'm not good enough, I'm not strong enough to beat this, you know, that kind of thing. So, and I think that's, and also you also see that some people will turn down some actually good treatments because they feel like, well, if I'm a strong person, I can beat it in this sort of way, you know, the old-fashioned way. So I think these conversations are helpful for younger folks to understand that there is actually a biological, you know, reaction, you know, and so the more your body gets, you know, a certain substance, and it's not everyone, of course, but there's a certain group of people who are going to be vulnerable, and if you have this reaction, your body then will have like a withdrawal kind of thing, and you need more of it, right? And so, you know, to sort of reduce that withdrawal, and then you also need more of it to get the same effect that you got initially. Like the first time you do something, you get that effect, and then over time your body kind of has a tolerance to it, and you need more and more of it, and that's how the pattern can kind of be. That's the early signs for a person to know. Gee, I used to just do that one week, and now I need, you know, 2 or 3 to get that same feeling. That could be one of those sort of warning signs for a person to realize, well, you know, maybe there's something else here. Now, there's some people who can do that one drink indefinitely, and it's never more than that, and that's fine. Or that one whatever vape, whatever. But the many other people, they need more and more over time, and that can be the warning sign that there's something else amiss that they might need to be mindful of.
Yeah, and just as you mentioned, like with like vaping as well, would you say that addiction would be more prevalent in adults or adolescents in like nowadays?
Well, I'll say this. I mean, and you can chime in as well, Dr. Whyte. I'll say that. So experimentation, you know, so use of these things is quite prevalent among adolescents. You know, I mean, there's a group, there's an organization that I can't think of, Dr. Whyte. It's a national. I forgot what it's called now. They do these surveys every year about you know, the amount of use among adolescents, first time use of, you know, how many adolescents from, you know, grades 12 have consumed, by grade 12 have consumed smoked or have consumed marijuana or have had alcohol use, and they trend this out over time, over decades. This data goes back decades. So I would say that it's common, right, in adolescence, but I would say that it typically becomes more of a problem for people, more and more people as they get older. You know, there's a subset of people for whom, because the natural, like a lot of people may experiment or use in some form, but then they will at some point in their life either curtail or stop altogether. But there's a subset of people who will not, and they will go on to develop problems. And so I would say that the more severe problems tend to be seen in people that are somewhat older, but really it covers the lifespan. I mean, it really covers the lifespan. And these problems, there's no group you can say, well, I'm safe because I'm this age or that stage of life. I mean, I see people in their 70s and 80s who are still dealing with pretty significant, you know, alcohol and drug problems. So it doesn't like, there's no point which you can sort of outgrow it. So everyone's potentially vulnerable. What have you seen or thought about it? What do you see?
I agree with that. I also think it's the cumulative effect over time that impacts the body. I mean, as you all know this, even at your age, there's also the impairment that these cause that put you at risk in terms of driving, boating, you know, scooters, bicycles, car issues. We've all seen that where people have been impaired. It's not just always the driver, but sometimes it's the pedestrian as well that's impaired and gets injured. So I know, and you'll hear this too. You think you're invincible when you're young, and certainly getting diseases is not common when you're young, but that doesn't mean that you don't want to think about your risk in terms certain conditions. And, we don't think about it when we're young. Well, what does this mean 20 years from now? I'll just do a little smoking now, or a little weed now, or, some drinking now, because I'll be fine. But we've all seen people, I'm sure Dr. Tweedy has as well, that, then go down a slippery slope, and it becomes 10, 20 years, liver damage, diabetes, other challenges.
Yeah. And so
and there's also greater awareness too now. So that can also help in terms of the amount of diagnoses that we have. We're much more aware of it. I'm sorry, Dr.
Yeah.
Tweedy.
No. And I would say in the younger generation, yeah, I would say the risk is true. The risk is less about sort of addiction per se, but more sort of the hazardous use and impaired judgment and accidents that lead to it. I mean, yeah, I think about some situations where I've had patients who've had problems with like impulsivity, where they've, they've been intoxicated, they've done just, dangerous things, some drowning. People I know who have got great swimmers, but didn't, intoxicated, and thank God they take these risks. And they drown, So those are the kind of things I think a younger group is more at risk for. It's less this. And then I would say, as far as the cumulative effect, if you take a group of 10 people who are sort of drinking, that binge drinking, like you might see or hear about people in college, one or two of those people is going to probably continue to have a problem into the future. That maybe, more of them won't and will, but there will definitely be some who will continue to have problems into the future. And so for those people, sometimes it's better not to even have gone down that path to begin with. And so I think that's something to be mindful of, particularly if you think about what your risk might be as well.
And kind of adding on to that, this is kind of directed at Dr. Tweedy, but what are the different treatment options for these kinds of things? Like, to what extent does medication versus therapy help?
So I know you guys are kind of covering these two different subjects. So if we were going to focus on the substance abuse or the addiction, they're actually increasingly more, actually. So, historically, the whole model was you would kind of do something like, Alcoholics Anonymous, and that's still helpful for many people, or something like that, and that would be your only sort of way to approach treatment. I think there's still a lot of value in programs like that, and other sort of programs like that. But so for instance, for people with nicotine or tobacco problems, there are some medication, they call them medication-assisted treatments. So they're medications that can help you reduce your cravings and help you make it easier for you to minimize the withdrawal, make it easier for you to stop smoking. The same is true for alcohol. There are some medications that are available, and it's also true for opiates. I mean, so for opiates, there's this medication called Suboxone, which has been gotten for a long time. Has been hard to access for people, and it's still has gotten easier, and that's part of this sort of destigmatizing thing that we're talking about. And so that's going to be really helpful with helping people sort of maintain, a drug-free life, for lack of for a better phrase. And so, but there's resistance in some corners to that approach. But I think it's an approach that can be helpful as part of a just a more regular, the traditional sort of approaches to treating substance use. But so I would say a combination of the medication treatment as well as the psychotherapy kind of treatments are both really helpful. And sorry. And so that was the addiction part. But as far as the depression piece, I mean, that's different. So with depression, there have been medications that have been around a long time that are used in the treatment of depression. I like to think of it as a tool, but not like the sort of panacea. I mean, I think some people come into it seeking sort of like a pill to fix their whole life kind of thing. And sometimes that's the same thing that led them to this path of addiction and things to begin with. So you have to kind of, be mindful of that. Counseling of different forms, whether it's, individual, group, there's a lot of different ways, a lot of different treatments for depression that are also extremely helpful. I think we're only beginning to tap into the idea of like things in psychiatry, like to what extent does the food we eat impact our mental well-being? I think we're only beginning to sort of tap into things like that, which I think are really important, have been for a long time been neglected. But you got to imagine that, the brain is an organ, right? And you got to imagine that some of what we're putting in our body is impacting it in all sorts of ways. So I think that's a really, if you think about the future of psychiatry and the future of these areas, I think that's something that we're going to hopefully learn more about and be able to incorporate in regular sort of treatment approaches to people.
Have you seen, like, to what extent, if someone is dealing with addiction, would you say that they could be more prone to having depression, or like vice versa? Is it like a correlation between the two?
Yeah, I'm sure, Dr. Like you've seen some of that, right?
Absolutely.
Yeah. Actually, I'm curious. This is something I think this is a point you guys maybe a little bit in the weeds for this audience, but one of the interesting pieces is that, so I'm a psychiatrist. Dr. Whyte, you're in internal medicine, primary care. So most people with depression or any sort of addiction problem, you're going to see someone like Dr. Whyte first, much more likely than you're going to see someone like me. So I'm curious to hear your perspective on that, Dr. Whyte, how you approach these, because you're like in the first pass.
Absolutely. What I think we've made a lot of progress on, especially in bigger health systems, is a greater effort on screening. And often in the practices that I've been in, the nurses and medical assistants will screen all patients ahead of time with a certain tool that Dr. Tweedy knows in terms of a depression scale. And there are different ones. Sometimes there's 2 or 3 questions which give a lot of data, and other times there's 9 questions or more. We do it for anxiety as well. And we might start with that first, because that's in some ways easier to administer, and patients kind of are used to that. Whereas asking about alcohol and smoking and all that can be a little jarring for people. But as you explore it, you see there's codependence too. When people have one substance, it's often another. It's often alcohol and drugs or something else. So they exist separately, but many, many times we see them together. And to Dr. Tweedy's point, you're right. Most people with depression and substance abuse come see a primary care physician first. And sadly, there aren't enough primary care physicians. They're overworked. This isn't typically higher on their radar screen. They're worried about managing diabetes and lipids and other things, because that's often what they're measured by in terms of the quality of care. So often it's missed, or often it's, we'll talk about that the next visit, or let's see how you're doing later. But in many ways, mental health is a continuum where it can be multiple issues going on at the same time, and then separately at different times as well. And we're not always good about treating them when there's multiple factors going on. And sadly, Dr. Tweedy's point, in terms of depression, oftentimes primary care physicians will simply do is medication, and that's it, and then wonder why people aren't getting better. So
Exactly. Yeah, I'm glad you brought all that up, because my wife's a primary care physician, and we have these sort of conversations, a lot. But yeah, so and just to follow up with your question, I would say yes. So like depression, untreated or inadequately addressed depression can certainly make someone who's prone to alcohol or drug use, can make them relapse. It can make them more likely to consume more. So there's definitely they definitely overlap. And then many substances, they affect your brain, right? They have physiological effects. And so people who consume large amounts of alcohol, we call sedatives. They call them downers for a reason. Like historically they would call some of these drugs uppers and downers, right? So and so that's the old terminology. And so it's drugs like alcohol and
we're dating ourselves.
I know. I'm old. I know. I don't want to even. Yeah, but it's very true. It's funny you mentioned it, because today we were giving in the class I was teaching. The professor was talking about trying to come up with an acronym, and she used VCR. These students probably half of them don't even know what like a VCR. My kids don't even know what a VCR is. Speaking of dating yourself,
don't embarrass yourself, Dr.
I know, right? Exactly. But as far as your question, yeah. So certainly, certain drugs like alcohol and opiates, they can cause people or chronic use can cause you to have depression and actually induce depression. And then when you withdraw from like stimulant, like if you're using stimulant drugs like cocaine or amphetamines, and you suddenly stop, you have a withdrawal, and that can cause depression. And so there's actually very clear physiological, well-characterized syndromes. So there's a lot of overlap between the two. There's a lot of overlap between the two syndromes.
Yeah, thank you so much for your insight on these topics. We know it's something that's on everyone's minds, especially a lot of like adolescents and kids our age, since we're like moving on to college, and a lot of people are more see some of these like issues.
Mhm.
But now we're going to transition a little bit to talk about health disparities and how they relate to addiction and depression. So, Dr. Tweedy, in your book, you talk a lot about how socioeconomic factors such as income impacts one's susceptibility to quality care. Can you specifically address how this relates to addiction or depression?
Well, I would just say, I mean, just to take the sort of the broader view, I mean, there's a lot about poverty and being deprived, and that's just really bad for your health across all facets. Whether it's just the stress of sort of navigating neighborhoods, lack of access to care. There's just so much of that that's just really can drive health and adverse health, and then how people cope with with the traumas that they experience. Right, you're more likely to experience. There's this. You guys may or may not be familiar with this. There's this thing called like ACEs score. It's adverse childhood experiences, adverse childhood exposures, I believe. And there's several different things on this list. And this was studies done years ago, but basically there are all sorts of things that are much more likely to be associated with being in an impoverished or situation. And it's much more likely to, people like that are more of those adverse experiences you have, the more likely you're going to have to be susceptible to depression and to substance use. I mean, there's pretty clear correlations between that. So, I mean, there's no doubt that that's a huge aspect. So there's that socioeconomic component. There's also, there's also racial aspects, right, too. So race and socioeconomic class, there's a lot of it's hard to disentangle because historically there's been so much, there's often so intertwined. But there's no doubt that there are, aspects to racial identity itself, which can also be complicated and have their own sort of traumas and challenges. So to the extent that, it makes someone, it's not that it would, how can I put this? Because there's different features to it. One aspect is, because I think, again, addiction and depression, because there's a biological nature to it, it transcends some of this, right? It affects all parts of the population. But I think the treatments that are available differ quite a bit depending on where you are and what setting you're in, how much access you have to different options. That varies tremendously. And so in that, to that degree, outcomes vary a lot. I've had just this amazing thing about but Dr. Whyte, when I was in medical school, I remember people, some professors, in med school, you sort of learn this, you get this sort of discussion about how with race, the black people in America have worse than every sort of barometer. But there was this idea about among people that somehow black people weren't depressed or were less likely to be depressed and that were somehow more resilient. And so in some ways it sounds appealing to think about, oh yeah, we're strong, we've overcome all this. It's also problematic because it then also makes people less likely to they might see black patients are less likely to take it seriously, address it if it's real. They say, oh well, it's not a problem for you guys, sort of thing. And so I would say that there's a lot of layers to that. I mean, I know it's a long-winded answer to your question, but I would say suffice to say that it does matter. Class, race, that stuff really matters when we talk about how people approach these issues. And how what access they have to care for those issues. It matters a great deal. Can I say one more thing? I know I ramble, but as I'm talking, I get an idea. To give you a visual example of this, so when I was in training, we see people addicted to substance abuse disorders all the time. So people who are in the kind of public clinics, people who are sort of in the either uninsured or Medicaid uninsured, what they would get was they would come into the hospital and they'd get like what we would call detox. They get like 3 or 4 days in the hospital, and then just be sent out. And good luck. But then in my training, I also had a chance to work at a substance use treatment facility. They're like a 30-day program. Very nice. I mean, it's like the person got all the medical part done, but they also got a chance to really explore all the psychological dimensions of it. The family was involved. It was comprehensive care. So how can we expect people with with those different levels of care to have the same outcomes. I mean, it's just like self-fulfilling. Like we're already sort of creating, like the disparities already exist in society, and then we in medicine are then just sort of furthering it. Because you're going to have a much less likely chance of doing better if you're getting crappy care. And so it's very real. So sorry for that long answer, but it just sort of touched on something I was thinking about for a long time.
No, that's very true. And I've seen it firsthand as well. Like people in more impoverished areas are at a much larger disadvantage to begin with, like you said. This is a little bit off topic, but we wanted to know how you think health insurance comes into play. Dr. Whyte, feel free to jump in as well. We know it's a very controversial topic, but we would like to hear both of your views.
Yeah, I'd like to hear your thoughts, Dr. Whyte.
Sure. And I did work at the Medicare program a while back. Health insurance plays a critical role. It's about access. That's a key component. It goes to Dr. Tweedy's point. If you don't have access to care in a top-notch treatment center that focuses on your entire 360-degree approach, you're not going to get good outcomes. If you can't afford the drugs because you don't have any insurance to cover it, or you can't afford the copay, you're not going to fill them. Well, let's just be realistic. And I will tell you, patients often are embarrassed about that and won't tell you that they're not taking their medicines because they can't afford them. And we don't work with patients enough to find out. I mean, access isn't the only aspect of your outcomes, as we talked about. The social determinants of health have a critical role in terms of where you live, your access to fresh fruits and vegetables, ability to walk, but absolutely, insurance is the critical aspect. Because if you're having issues, say, with substance abuse or depression, and you don't have insurance, you're not going to be able to get care. And where do you end up? You end up in the ER when there's been an incident that perhaps puts your life at risk, either in depression or in terms of addiction. So it's a major aspect of getting good care. It's the first step.
And the way we criminalized some of the drug use historically, some people end up in jail. So it's like they end up in jail because of the criminalization piece. They end up in the ER, like you said, they're not getting the care that they ultimately need. So Dr. Whyte, I'm curious. I think about health insurance as like a necessary, it's not sufficient, but it's certainly necessary. Like the political debates we've had about health insurance have been about, whether we should do it or not do it. It seems like the political debate should be about how we do it. I don't know if you feel like that conversation has been shifting. I feel like, because it's like 15% of the population uninsured, tens of millions of people that don't have health insurance. But do you feel like the conversation is shifting at all in terms of like being more about how we do it versus whether we do it? I'm curious.
I don't think there's any desire for universal single payer, universal care,
Right.
Expanding Medicare to the entire population. I just don't think there's the political will. Where we're seeing progress is ensuring what we call safety nets, kind of an inside the beltway term, and others. How do we at least provide minimal care? How do we expand Medicaid, which often addresses children? That's where I think we're seeing progress. I think a lot of people would like to see universal access, healthcare being more affordable, drugs being more affordable. But unfortunately, the environment is so political or partisan, we're not seeing a lot of progress in that front. Although I think with the ACA and some Affordable Care Act under Mr. Obama, as well as some changes that we've seen as a result of pandemic funding, we have progress, but we have a long way to go. And the other aspect that I want to point out, we have to be particularly vigilant, and that's why I'm happy you're having this discussion, is we know that, I'm kind of shifting a little bit, but hopefully you'll see it. The point is, COVID is an infectious disease pandemic, but we're having a mental health pandemic that's just going to continue long after COVID is resolved. And we need to have the safety nets available for people so they don't fall through the cracks and don't get care or get substandard care. And we need resources for that.
Yeah, that mental, oh gosh, we tracked our consults over the past year. and compared to the previous year before that, and it's doubled. Mental health, consults we've gotten. I mean, it's no doubt. It's been such a challenging 18 months for many people.
Yeah, so there is a question in the chat kind of relating to what Dr. Tweedy said before about racial bias and prejudice against patients of different races. Someone was wondering whether doctors are kind of like underhandedly taught these assumptions in med school and their careers. So would either of you be able to expand a little bit on that?
Yeah, and I apologize, I'm going to have to leave a little around 6. I think what we're referring to, first we have to remember that the medical community is primarily Caucasian. We've made a lot of progress in the terms of number of women in healthcare and in medicine, but it's been primarily Caucasian women. The number of Black men in medicine has not changed much in 50 years overall. So we're starting off with that we don't have doctors that look like people of minority groups. So that's a challenge. And I've been very interested in this concept of what's called implicit bias. So if you ask someone, they're going to say, I don't treat people differently based on the color of their skin. But we know they do from studies in terms of whether patients get referred for certain types of cardiology procedures, whether or not they get lipids, whether they get pain medication in the ER. I mean, it's that simple. Even recently, children, how they're being treated, Black children versus white children in terms of appendectomies, that, should be the same type of care for appendicitis. That's because of implicit bias that a doctor thinks, I'm not going to offer you that care, or you won't be able to participate in that clinical trial, or whatever. It exists, and people aren't self-aware and acknowledge it enough. I don't know if you agree with that, Dr. Tweedy, but
no, I do, and I think medical schools, the medical education system has perpetuated some of those biases for a long time, the way that it's been taught, and they're only more recently beginning to sort of challenge that and confront it and figure out more creative ways to not do that. Because I think that's the future. And I would also say that the future is many of the students I work with are much more in tune to these issues. Like even the conversation you guys are having is the kind of conversation that we would not have had 20 years ago at all. So that itself represents change and hope for change in a way that didn't exist in Dr. Whyte and ours generation. So I really think that's I think that's a huge take-home point. The idea that you're talking about these issues at this stage, talking about addiction, talking about mental health issues, talking about disparities. I mean, these are huge issues that medicine has neglected for a long time. We're only beginning to really address. So I think I just want to say thank you guys for just even putting this together.
Yeah, for sure. Thank you so much for both of your insights. That brings our webinar to a close. In summary, we've discussed many relevant topics that we are sure many of our viewers will have new perspectives on. Is there anything else anyone would like to add?
You can always message me directly if they like.
Yeah.
I'm on social media, I answer my own emails. Folks can feel free to reach out.
Yeah, if there's stuff that we can get covered, folks can email me. You guys have my email address. You can send me an email and I'll be happy to address what but I really apologize for the late start. I was working with a group of students, and actually we were talking about some of these very topics. And it was a really heavy conversation with these medical students about some of these issues. So again, it gives me hope for progress that we're sort of moving forward. And so just feel free to message me on the back end. And Dr.
For sure.
See you again.
Yes,
thank you
nice
so much to our
Bye-bye.
panelists, Dr. Tweedy and Dr. Whyte. We're ever so grateful to have had you join us on this Wednesday evening, despite your very busy schedules. And it truly means a lot to us and our community that you were here to join us today.
Thank you.
Thanks, guys.
Bye-bye. Have a good night.
Everyone viewing, we're really appreciative that so many people decide to join us. And if you would like to stay on top of what we are doing in our club, follow us on our Instagram at Bedford _HOSA.